Hi, and welcome back to the ProPA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into some essential vascular topics: peripheral artery disease, arterial embolism, and thrombosis. We'll cover everything you need to know to recognize, diagnose, and manage these conditions in the primary care setting. Let's get started. Starting off with some pathophysiology, peripheral artery disease, or PAD, is a chronic progressive disease caused by atherosclerosis, which leads to narrowing and occlusion of the arteries supplying the lower extremities. Over time, this reduces blood flow and can result in claudication, rest pain, or non-healing wounds, ulceration, and gangrene. On the other hand, arterial embolism and thrombosis are acute events. An arterial embolism occurs when a clot or debris breaks off from a proximal source, such as the heart or an atherosclerotic plaque, and travels downstream, suddenly occluding an artery. Arterial thrombosis is a local formation of a clot within a diseased artery, often due to a ruptured atherosclerotic plaque. Both can lead to acute limb ischemia, which requires urgent intervention. Now, who do these conditions affect? PAD is most common in adults over 50, particularly those with risk factors like tobacco use, diabetes, hypertension, and hyperlipidemia. It's often seen in patients with a history of cardiovascular disease. Arterial embolism and thrombosis can occur in a wider population, but emboli are frequently associated with atrial fibrillation, while thrombosis is more common in patients with underlying atherosclerosis. As far as the clinical presentation, patients with PAD often have no complaints. However, if the supply of blood fails to satisfy ongoing metabolic requirements because of arterial narrowing, symptoms will occur, the severity of which depends upon the degree of arterial narrowing, the number of arteries affected, and the activity level of the patient. PAD can present with pain of one or more lower extremity muscle groups related to activity, which is intermittent claudication. This kind of pain is usually relieved by rest. It can also present with atypical pain, pain at rest, or with non-healing wounds, ulceration, or gangrene. In the case of acute limb ischemia due to embolism or thrombosis, patients may have the 6 Ps, which would be pain, pallor, pulselessness, paresthesias, paralysis, and poikilothermia, which is a cold limb. Sudden onset of symptoms suggests embolism, while a more progressive onset most likely suggests thrombosis. Moving on to the diagnosis, for PAD, you want to start with an Ankle-Brachial Index. This is an ABI. A ratio of less than 0.9 is suggestive of PAD, while less than 0.4 indicates severe disease. For acute limb ischemia, clinical presentation is key. Patients with viable or marginally threatened limbs are usually candidates for urgent vascular imaging. This is typically a CT angiography or catheter-based arteriography. This helps to evaluate arterial anatomy and to potentially institute thrombolytic therapy. However, patients with an immediately threatened extremity should preferentially undergo further evaluation and treatment in a surgical suite. Regarding management, cardiovascular risk reduction is going to be key. This can be done through lifestyle modifications such as smoking cessation, diet, exercise, and weight loss if applicable, pharmacologic therapy with an antiplatelet like aspirin or clopidogrel, and lipid-lowering therapy with a statin. And also, don't forget maintenance of blood pressure and glucose at recommended levels. For patients with lifestyle-limiting claudication who do not have an improvement in symptoms with risk modification and exercise therapy, a therapeutic trial with cilostazol can be tried. And revascularization is reserved for severe cases. Options are angioplasty or bypass surgery. The choice depends upon the level of obstruction, the severity of the disease, the patient's risk for the intervention, and the goals for care. And the management for acute limb ischemia, include immediate anticoagulation with heparin and possible revascularization. Now, preventing PAD involves aggressive risk factor modification. Controlling diabetes, hypertension, and hyperlipidemia are very important, along with regular physical activity. And for high-risk individuals, routine ABI screening may be necessary. And in the case where atrial fibrillation is the cause of embolism, then proper management of the AFib is key. Now, book med versus street med. Textbooks emphasize a stepwise approach, starting with medical management before considering revascularization. In real-world practice, though, many patients present late with severe disease and require urgent intervention. In primary care, our role is in early identification and risk factor management to prevent progression. Here are some clinical pearls. Number 1, a normal ABI doesn't always rule out PAD. Patients may have falsely high readings due to calcified vessels, such as in diabetes, chronic kidney disease, or the elderly. Number 2, sudden onset ischemia usually indicates embolism, whereas progressive symptoms usually indicates thrombosis. Number 3, claudication is reproducible. If pain is variable or not relieved with rest, consider alternative diagnoses. Now, let's practice some clinical questions. Question 1. A 67-year-old man presents to your clinic with progressive pain in his right calf while walking that is relieved with rest. He has a history of hypertension and smoking. Physical exam shows hairless, shiny legs with diminished pedal pulses and an ABI of 0.7. Which of the following is the next best step in management? Is it A, order an arterial duplex ultrasound, B, initiate aspirin and lifestyle modifications, C, refer for immediate surgical bypass, or D, prescribe cilostazol regardless of history? I'll give you a couple of seconds. If you chose B, initiate aspirin and lifestyle modifications, you are correct. This patient has PAD with claudication. First-line treatment includes antiplatelet therapy, a statin, and lifestyle changes. Duplex ultrasound is useful but not required unless intervention is planned. Question number 2. A 67-year-old man presents to your clinic with complaints of intermittent cramping pain in his calves that occurs while walking and is relieved with rest. He denies any recent trauma, swelling, or redness in his legs. His medical history includes hypertension, hyperlipidemia, and a 40-pack-year smoking history. On physical exam, his lower extremities are cool to touch with diminished dorsalis pedis pulses bilaterally. Which of the following is the most appropriate initial diagnostic test? Is it A, venous duplex ultrasound, B, Ankle-Brachial Index, C, arterial biopsy, or D, contrast-enhanced magnetic resonance angiography, which is an MRA? If you chose B, Ankle-Brachial Index, you are correct. The Ankle-Brachial Index, or ABI, is the preferred initial diagnostic test for PAD as it is non-invasive, widely available, and provides a quick assessment of arterial perfusion in the lower extremities. An ABI of less than 0.9 is diagnostic of PAD. Venous duplex ultrasound is used for venous disease. Arterial biopsy is not indicated, and MRA is typically reserved for cases requiring further vascular imaging before intervention. Great job! Thank you for tuning in to this episode of the Pro-PA podcast. PAD, arterial embolism, and thrombosis are critical conditions that primary care PAs must recognize early to prevent complications. If you found this helpful, don't forget to subscribe and turn on notifications for future episodes. And as always, this is the Pro-PA podcast, where future pros in medicine are made. See you next time.